Welcome to our comprehensive guide on joint mobilization. In this video, we'll explore the essential techniques and gradings used in physiotherapy to restore joint function, reduce pain, and improve mobility. Whether you're a student, a practicing therapist, or simply curious about how joint mobilization works, this video will break down the concepts in a clear and engaging way. We'll start by introducing the basic principles, then move on to specific techniques like traction and oscillation, and finally, we'll look at practical applications for individual joints, such as the sternoclavicular and acromyoclavicular joints. Let's get started on this journey to better joint health and understanding. Traction joint mobilization is a foundational technique in physiotherapy. It involves applying a gentle pulling force to a joint, aiming to separate the joint surfaces and relieve discomfort. This method is especially useful for reducing pain and increasing the extensibility of the tissues surrounding the joint. Traction can be performed at different grades, each with specific therapeutic goals. In the next scenes, we'll break down these grades and their unique uses. Understanding traction is crucial for anyone looking to enhance joint mobility and manage pain effectively. Traction joint mobilization is categorized into three main grades. Grade 1 is used primarily for pain reduction, applying a small amplitude distraction. Grade 2 serves a dual purpose. It not only reduces pain, but also increases periarticular extensibility, making the tissues around the joint more flexible. Grade 3 is more intensive, focusing on correcting positional faults and reducing spinal disc herniation by stretching the joint capsule and breaking adhesions. Each grade is chosen based on the patient's needs and the specific therapeutic goals. Selecting the right grade ensures safe and effective treatment. Oscillatory joint mobilization is another key technique used in physiotherapy. Unlike traction, oscillatory movements involve rhythmic, repetitive motions that help to mobilize the joint surfaces. These movements are performed parallel to the concave joint surface and can vary in amplitude and speed. Oscillatory techniques are graded from I to V, each with distinct characteristics and therapeutic effects. This method is especially effective for reducing pain, increasing joint flexibility, and breaking down adhesions. Let's dive deeper into the specific grades and their applications. Oscillatory joint mobilization is divided into 5 grades. Grade I uses slow, small amplitude movements at the beginning of the range, mainly for pain relief. Grade 2 increases the amplitude but stays within the first tissue stop, targeting both pain and flexibility. Grade 3 involves large amplitude movements up to the first tissue stop, while Grade 4 uses small amplitude movements slightly beyond this point, both aiming to increase extensibility and correct postural faults. Grade V is a thrust technique performed quickly to break adhesions and address spinal disc herniation. Each grade is selected based on the patient's condition and treatment goals. Each grade of oscillatory mobilization serves a specific purpose. Grades I and II are primarily used to reduce pain, making them ideal for patients in the early stages of rehabilitation or those with acute discomfort. Grades III and IV not only alleviate pain, but also increase periarticular extensibility, correct postural faults, and help break down adhesions. Grade V is reserved for more advanced cases, such as reducing spinal disc herniation and breaking stubborn adhesions. Understanding when and how to apply each grade is essential for effective joint mobilization and optimal patient outcomes. Proper timing and combination with other modalities are key to successful joint mobilization. Traction is typically applied for about 10 seconds, followed by a rest period of several seconds. Oscillatory movements are performed at a rate of 2 or 3 per second for about 1 minute. These techniques can be combined with other treatments such as wax baths, hot water fomentation, massage, interferential therapy, IFT, and ultrasound for enhanced results. This integrated approach ensures comprehensive care, addressing both pain and mobility issues effectively. Let's focus on the sternoclavicular joint, a key joint connecting the upper limb to the trunk. This synovial, saddle-type joint involves the medial end of the clavicle and the clavicular notch of the manubrium sternum. It is stabilized by several ligaments, including the anterior and posterior sternoclavicular, interclavicular, and costoclavicular ligaments. Understanding the anatomy of this joint is crucial for effective mobilization and injury prevention. In the next scenes, we'll explore the movements and specific mobilization techniques for this joint. The sternoclavicular joint allows for a variety of movements, including elevation, depression, protraction, retraction, and rotation. Each movement is facilitated by specific muscles, such as the trapezius, levator scapulae, rhomboids, latissimus dorsi, and pectoralis major and minor. Understanding these movements and their associated muscles helps in diagnosing joint dysfunction and planning effective mobilization strategies. Next, we'll look at the arthrokinematics and how these movements translate into joint gliding techniques. Arthrokinematics describes how joint surfaces move relative to each other. For the sternoclavicular joint, elevation involves caudal gliding, while depression requires cranial gliding. Protraction is achieved through ventral gliding and retraction through dorsal gliding. Knowing the starting, resting, and close-packed positions of the joint is essential for safe and effective mobilization. The clavicle typically lies in a horizontal position at rest, with full elevation representing the close-packed position. In full elevation, the joint's capsular pattern is most restricted. Mobilizing the sternoclavicular joint involves several specific techniques. Cranial gliding increases depression movement, while caudal gliding enhances elevation. Ventral gliding is used for protraction, and dorsal gliding for retraction. Each technique requires proper patient positioning, usually supine lying, and careful therapist hand placement for effective and safe mobilization. These methods help restore joint play, reduce pain, and improve shoulder mobility. Let's look at each technique in detail, including therapist positioning and hand placement. The acromioclavicular joint is another important joint in the shoulder complex. It is a synovial, plane-type joint formed by the lateral end of the clavicle and the medial margin of the acromion process of the scapula. This joint is stabilized by the acromioclavicular and coracoclavicular ligaments. Its movements mirror those of the sternoclavicular joint, with elevation involving dorsal gliding and depression involving ventral gliding. Understanding the anatomy and movement of this joint is essential for effective mobilization and overall shoulder health.